Okay, I think it's time to start. Sorry, I'm just looking for my screen. Can you see my screen still?
No, not yet. Yeah. But nothing SSBD.
Yes, we can see your screen.
Okay, so welcome everyone. Good evening, and thank you for being here. Tonight we are having a very exciting meeting with a presence of excellent speaker and big names in the field of multiple myeloma. This webinar is sponsored and organized by the SSBD. So we will go through interesting discussion in the field of multiple myeloma in Saudi Arabia, the current and the future. So the first part will be presented by Professor Robert Orlesky from USA MD Anderson about the management of relapsed refractory multiple myeloma in 2021, followed by 5 minutes of questions and answer. Following that, Dr. Fahad Sharif will talk about myeloma care in Saudi Arabia, mainly the opportunities and challenges. Then another talk by Professor Orlesky about overcoming challenges in optimizing care in multiple myeloma, and after that we will have a discussion and for 25 minutes and taking questions and answer to all speakers. And then we will be closing the webinar. So we will, okay. So just to remind everyone, this session will be recorded and you can find the full recording of the webinar, which will be available in the SSBD channels, either in YouTube or Twitter. So we will start our webinar today by a lecture presented by Professor Robert Orlesky about the management of relapsed refractory multiple myeloma in 2021. So just, I think it is very hard to present our speakers tonight because they're very well known. So Professor Robert Orlesky works in the Department of Lymphoma and Myeloma as a division of cancer medicine at University of Texas MD Anderson. And in Florence Maud Thomas Cancer Research Professorship in Department of Lymphoma and Myeloma, Division of Cancer Medicine at University of Texas MD Anderson. He is the director of section of Myeloma, Division of Cancer Medicine at University of Texas MD Anderson. Professor Robert had his postgraduate training, internship, and residency internal medicine in Washington University, St. Louis School of Medicine. He had his postgraduate fellowship in medical oncology at Johns Hopkins Oncology Center, Baltimore, then another postdoctoral fellowship in adult hematology at Johns Hopkins School of Medicine. Professor Robert has an extensive contribution in research field, many publications, abstract, and is a principal investigator in many phase 1, 2, and 3 trials. He is a member in many societies, not only in the field of hematology, but also in biochemistry and molecular biology. Received several awards in the field of academia and administration. So without further delay, we will go ahead with our first lecture about the management of relapsed refractory multiple myeloma in 2021. Welcome, Professor. The field is yours.
Shukran. Thank you very much for inviting me. It's a great privilege, and I hope very soon to be able to come and meet all of you in person once we can hopefully get rid of our mutual enemy, which is COVID. And you'll see in my slides that I have the goal for that up in the upper left corner. These are my disclosures for both laboratory and clinical research, as well as advisory boards. I'm sure you know that patients with myeloma have been doing better and better over the years as a result of the improvements in upfront therapy. But still, you can see that even with our modern treatment, there is no plateau in the survival curve. So we don't yet have a cure. And despite the fact that initial treatment is better, people still develop relapsed or refractory disease, which is therefore a challenge. Just to give you some definitions for the rest of the talk, relapsed disease is considered progression when the patient has not been on therapy. And we don't see that very much anymore because of the tendency to continue treatment until progression. Whereas refractory disease is progression on treatment or within 60 days of the last treatment. And on occasion, which now fortunately is rare, there are primary refractory patients who never achieved at least a minor response, which means at least a 25% reduction in disease burden. Right now, by the way, there is no standard definition of refractory based on the drug dose. For example, if someone is on full dose lenalidomide at 25 milligram along with dexamethasone and they progress, they're considered to be similarly refractory as if somebody is on a maintenance dose of lenalidomide at 10 milligram. These are the most recent and now the fifth version in just 2021 of options according to the NCCN for therapy of relapsed and refractory disease. And you can see that there is very good news, which is that there are lots of options. But there also is bad news, which is that there are lots of options, and it can be difficult to select which option is the best one, especially because many of them are not necessarily compared head to head. But what I'm going to try to do, because this is a very sophisticated audience that knows a lot of the data in this area already, what I'm going to focus on are some of the more recent drug approvals and therapies. And in this talk, I'm going to mostly focus on early relapsed or refractory disease. And I've defined that as patients with 1 to 3 prior lines of therapy, although many of these patients can also, sorry, many of these regimens can also be used in later lines of therapy. These are just some principles that I follow in treating patients with early relapsed or refractory disease. First of all, many of them have been or are currently on lenalidomide maintenance, and many of them have already had bortezomib. On occasion, patients will have an indolent relapse where the M protein may be going up very slowly and there are no symptoms. In those cases, occasionally modifying the maintenance dose, for example, increasing the lenalidomide or adding another drug like a low dose steroid or ixazomib or elotuzumab may be appropriate. Unfortunately, a lot of patients fall into the aggressive relapse category, meaning that they have a rapid increase in their monoclonal protein, or they have aggressive clinically symptomatic disease, including hypercalcemia or new bone lesions. Probably they need a triplet with as many new drugs as possible. And so really, if they have not had an anti-CD38 monoclonal antibody yet, they probably should do so in the second line. And adding that to carfilzomib or pomalidomide, I think is very attractive. Let's start with a few of the options here. There are the data from the Icaria study, which looked at pomalidomide and dexamethasone versus isatuximab, pomalidomide and dexamethasone. Isatuximab, of course, is one of the CD38 antibodies that's currently available. Here you can see the response data, which show a nice improvement in very good partial response or better, as well as the overall response rate and a low rate of disease progression. For those of you that like to see the curves, here is the progression-free survival with the isatuximab curve in blue and just the pomalidomide and dexamethasone in red. And you can see by the hazard ratio that there's about a 40% improvement in outcomes with an almost doubling of the progression-free survival. And the overall survival data, although not yet fully mature, nonetheless do show a trend for an improved overall survival with isatuximab. Many of you have probably already used CD38 antibodies, but if not, in general, the significant adverse events that can be a little bit increased include infectious complications, a little bit more here, for example, with the triplet versus the doublet. And on occasion, of course, you can have some infusion reactions with dyspnea or cough. But in general, these antibodies are very well tolerated and don't generate a lot of cytopenias, although there is a little bit more anemia maybe, but probably not that much. There also is the option to use Daratumumab, which is the other anti-CD38 antibody. And the newest data set I pulled out from ASH that was given a couple of months ago looked at Daratumumab, which was given subcutaneously, versus pomalidomide and dexamethasone, which was equal in the two arms. You probably have seen the data with a nice overall response rate, 70% for the triplet versus a little less than 50% for the doublet. And here is MRD negativity, which is relatively low in this patient population. And that's because these are relapsed or refractory disease myeloma patients. And so the possibility to achieve MRD negativity is unfortunately lower, but you do get more MRD negativity with the triplet. Once again, if you look at the progression-free survival data, you can see that the triplet does better than the doublet. Once again, about a 40% improvement in the progression-free survival. If you compare the actual numbers, it's of course not fair to do that, but nonetheless, we all do it. The progression-free survival here with the Daratumumab combination is a little bit longer than with Icaria, but part of that is because this is an earlier patient population because they allowed second-line patients, whereas the previous study started with third-line patients. And here are the safety data where again, you can see maybe a little bit of an increase in neutropenia and also an increase in infections. But otherwise, these anti-CD38 antibodies are tolerated relatively well. Some of you may prefer to give a CD38 antibody with a proteasome inhibitor, and you do have the option to do that with bortezomib, but carfilzomib is also a good option, especially in patients who may be progressed on bortezomib before, or they have neuropathy due to bortezomib. And we really have two large data sets that we can look at. First of all, there was the Candor study that was published last year that looked at carfilzomib and dex as the comparator, and the experimental arm had daratumumab with carfilzomib and dexamethasone. You can see that these were patients that were pretty heavily pretreated, proteasome inhibitor already. 2/3 or more had had IMiDs, and about 20 to 30% were refractory to bortezomib, and about 30% were refractory to lenalidomide. Here you can see the response data. This is the Daratumumab group here, and this is just the doublet group here. And you can see that there is a higher complete response rate, a higher very good partial response rate, and overall it looks like a higher rate of minimal residual disease negativity. Once again, for those of you that like to see progression-free survival, you can see that the triplet in red separates fairly early and continues to separate the longer patients are able to stay on therapy. And again, with a hazard ratio of 0.63, that means almost a 40% improvement or reduction in the risk of progression. Here you can see the safety data. And if we just focus on the grade 3 and 4 events, which are of course the more serious, you have maybe a little bit more hypertension, and once again, a little bit of an increase in pulmonary and other respiratory infections, but in general, a well-tolerated combination. Most recently, we have also the possibility to use isatuximab with carfilzomib and dexamethasone. And this was a study that was called IKEMA, which was essentially designed similarly with KD or carfilzomib dex as the control and isatuximab carfilzomib dex as the experimental arm. You can see that these patients were fairly well balanced with, again, quite a large proportion that had IMiD refractory and lenalidomide refractory disease, and proteasome inhibitor refractory disease was present as well. Once again, the progression-free survival show that the triplet is better than the doublet. The hazard ratio here is lower, which suggests the possibility that the isatuximab KD combination gives you a greater benefit than the daratumumab carfilzomib dex combo. But again, we would need a randomized study. The other thing to keep in mind is that the progression-free survival in this study for the control arm was better than it was in the Candor study. And that makes the improvement in the outcome with the triplet even more impressive, because you have a lower hazard ratio, which means a greater benefit compared to a stronger control arm. Here you can see the response rate data, which gives you a very high overall response rate and almost 40% of patients having a complete response or better. And here you see that the MRD negative rates are quite high as well, including good rates of MRD negativity in patients with VGPR. And sometimes these VGPR patients are in VGPR just because the monoclonal antibody may interfere with the determination of a complete response. And if you look at various subgroups, you can see that essentially all of the subgroups, including patients with high risk disease and standard risk disease, whether they had prior IMiD or prior PI, and baseline glomerular filtration rate or kidney function, all of them did better with the triplet. And in fact, I think it's worth pointing out that folks that had a decreased renal function did especially well with this isatuximab-based combo, and maybe better than with the daratumumab-based combination. So that may be something to think about. Other combinations that I think you should definitely consider in this 1 to 3 prior lines of therapy, but only maybe in certain populations. First of all, about 10 to 15% of patients will have an 11-14 translocation, and these are patients that express higher levels of BCL2 in their myeloma cells, which makes venetoclax a good option to consider. You know, of course, about the Bellini study, which randomized patients to bortezomib and dexamethasone, or venetoclax with bortezomib and dexamethasone. You probably remember that the progression-free survival data was better for the venetoclax arm with a good hazard ratio, But unfortunately, for the overall survival, the venetoclax arm did worse. But the important thing to remember here is if you only pull out the patients with 1114 translocations, they had really excellent outcomes with higher overall responses. And again, just pulling out patients that had 1114, you can see that the venetoclax bortezomib dex arm did much better, 90% better than just bortezomib and dexamethasone. And these were the data for patients with high expression of BCL2. Again, almost a 75% improvement. So if you have a patient with 1114 translocation, I would definitely think about using this combination, maybe even before an anti-CD38 antibody. And then the other regimen I would remind you about is that of selinexor with bortezomib and dexamethasone, which was based on the Boston study that compared Bortez Dex to selinexor Bortez Dex. The main thing to remember here is that here the bortezomib was given twice a week, and with the selinexor, both the seli and the Bortez were given once per week. You probably remember that the triplet did better by about 30% than did the doublet. But the reason that I bring this up in particular is that although this was a small population, out of 37 patients with deletion of 17p, they actually did much, much better with the selinexor-based triplet. And because we don't have very good therapy for this typically high-risk subgroup, if you have a deletion 17p patient, I might think about using this combination. And then finally, we can always use our current drugs with new combinations. And probably the best example is the pomalidomide with bortezomib and dexamethasone combo, which we know gave a better overall response rate compared to just bortezomib and dexamethasone, and the progression-free survival was better, especially if it was used as a second-line therapy. And in many countries, bortezomib is now available in a generic form, so that may reduce the cost of this therapy, which makes it worthy of consideration. And here are the progression-free survival curves. So I think the conclusions that I would leave you with are, of course, due to earlier use of novel agents, once patients develop relapsed or refractory disease, it's more challenging now to manage. One option is to use our current drugs in new combinations, the example being, for example, bortezomib with pomalidomide, but we also have more novel or noveler drugs that are available and some that are coming out in clinical trials, and I'll mention a few of those in my second presentation. Again, this is an overview of what I do for relapsed refractory disease, especially if it's symptomatic or progressing rapidly. I really think that an anti-CD38 antibody-based triplet is the standard of care. And because many of these patients have been on lenalidomide, I think either a PomDex or a carfilzomib dex combination is best. And you can do either isatuximab or daratumumab with those two drug backbones. If you have 1114, definitely think about venetoclax, and deletion 17p. It may be that selinexor is the best therapy. I didn't talk a lot about elotuzumab, but it's also an option in combination with pomalidomide. And so you really have three different monoclonals from which to pick. We don't really have comparative studies that allow us to decide which one of these is the easiest. I don't use a lot of ELO simply because it seems not to have single agent activity. And so my preference is to do either the isatuximab or the daratumumab. And we do have some data that I'll show you later that you may be able to reuse an anti-CD38 antibody after it's been used previously. And if you have a high risk patient, do think about a proteasome inhibitor based regimen. We did recently publish, and we're going to be updating this, an algorithm that at least gives you a list of some of the combinations to think about using in relapse disease based on whether patients are frail or fit and have 1 to 3 or 4 or more prior lines of therapy. And we're developing additional tools that I hope to be able to present to you soon about that. And then finally, if you ever have any questions, these are our myeloma faculty at MD Anderson, and please feel free to email me directly. This is my email address, and I also have a Twitter account, and this is our telephone number for referrals. So thank you very much for your attention, and I'll turn it back over to our moderator to continue with the symposium.
Excellent. Thank you so much, Professor Orlesky, for very elegant, comprehensive review for most updated and most active treatment of in relapsed refractory multiple myeloma. So please post questions in the chat or the question and answer. Okay, since there are no questions, I think the common question in most of the meeting, a myeloma meeting, that there are still, with the novel therapies, with the targeted therapies, still there are many unmet needs for multiple myeloma patients, especially those who are not included in most of the clinical trials, including extramedullary plasmacytoma, mainly the soft tissue plasmacytoma, plasma cell leukemia, young patient with aggressive disease or high risk or ultra high risk, whether to manage as routine, like as the guideline, or we should consider more aggressive treatment. So I would like to hear your opinion. I think this is a very tough question that is commonly asked.
Well, it's a great question, and you've pointed out some of the higher risk populations that unfortunately still have poor prognosis. Those include extramedullary disease with soft tissue, as you pointed out, plasmacytomas, as well as plasma cell leukemia and ultra high risk disease. For those patients that have this as an option, if they had a long remission duration with the first autologous transplant, repeating an autologous transplant may be an option. In selected younger patients with very high risk disease, an allogeneic transplant may be an option if they have an appropriate donor. We have CAR T cells that are coming, and actually here in the US just on Saturday, the first BCMA targeted CAR T was approved. So hopefully you in Saudi Arabia will have that available soon as well. I usually like to use a more cytotoxic agent-based approach to these aggressive relapses. And so I still use quite a bit of cyclophosphamide, for example, and I like doing carfilzomib or bortezomib with cyclophosphamide. On occasion, we will even hospitalize patients and use a hyperfractionated cyclophosphamide-based regimen as a bridge to be able to get them to another therapy, such as a stem cell transplant. But you're right, these are definitely one of the unmet medical groups, the others being probably older and frail patients who don't tolerate triplets very well, and then still the very relapsed and refractory disease after anti-CD38, after proteasome inhibitor, after IMiD, and soon after BCMA targeted therapies as well.
Great, thank you. So another question, do you think the conventional FISH and cytogenetics are adequate to tell you, to differentiate between standard high risk or ultra high risk? There are other measures that we can, like about International Myeloma Working Group and ISS, but do you think, is it adequate, or we need to rely on more like next generation sequencing or more advanced genetic testing? Because there are some patients, yeah, go ahead.
No, please finish.
Oh, thank you. So there are some patients that have a standard risk, but they don't behave as standard risk. They behave more aggressive. So these patients make the clinician very anxious about managing them. So I would like to hear your opinion.
You're definitely right that there are patients who come out as standard risk according to the criteria and yet do not do well. And on occasion, we also see high risk patients who do much better than we expect. And I'll give you an example of where sequencing can be very helpful because you mentioned that. Deletion 17p is typically thought of as a high risk feature, but we now have data that if you have a monoallelic deletion 17p, but by sequencing your TP53 gene on the remaining chromosome 17 is normal, that those patients have a good outcome. Whereas if you have a biallelic deletion or a monoallelic deletion with mutation of the remaining copy of P53, that those patients are the ones that have a poor risk. So I think there is an excellent example of your point that sometimes sequencing can give us additional information that we otherwise would not have.
Perfect. Thank you so much. Any one of the panelists have other question, Dr. Fahad, or we can proceed for the next presentation? Any questions? Okay, Dr. Fahad.
Thank you. I have no question at this stage.
Perfect. Perfect. Okay, so next presentation will be presented by Dr. Fahad Sharif about the myeloma care and management in Saudi Arabia. What are the challenges we're facing and what are the opportunity? So everyone, I think, knows Dr. Fahad. Dr. Fahad is a senior consultant in the field of hematology and BMT with special interest in the in multiple myeloma. He is a professor in College of Medicine at Al Faisal University. He had his medical hematology and BMT fellowship at King Faisal Specialist Hospital and Research Center in Riyadh, followed by clinical hematology BMT fellowship at University of Toronto in Canada. Dr. Sharif is a very active in academic and scientific fields. He received several academic awards and participated in many scientific meetings. He has many contributions in research field with numerous publications and abstracts. And he is a member of several big society, including ASH, EHA, and ASBMT. He is currently the director of autologous stem cell transplant in multiple myeloma program. And he is a consultant hematology and BMT at Oncology Center in King Faisal Specialist Hospital and Research Center in Riyadh. Welcome, Dr. Fahad. It's an honor to have you tonight. The mic is yours.
Thank you very much, Dr. Mutahhar, for this nice introduction. I would like to thank Dr. Faraz Al-Freih as he personally invited me to participate in this activity. I would like now to go ahead and to share my slides. Okay, share, that's good. Okay, now I think you can see my slide very well.
Yes.
بسم الله الرحمن الرحيم وصلى الله على سيدنا محمد وعلى آله وصحبه وسلم. I'm going to talk tonight about multiple myeloma care in Saudi Arabia, the opportunities and challenges. In fact, during my talk, I'm going to touch upon the following issues, and finally, I will conclude within 20 minutes. In Saudi Arabia, the exact incidence of multiple myeloma is largely underreported. According to the WHO country profile, multiple myeloma and lymphoma accounted for 9.6 to 11% of cancer. Okay. Cancer-related death in the kingdom in 2014. In 2014, also, Saudi Cancer Registry reported that multiple myeloma accounts for 1% of total cancer cases with an age-standardized incidence of 1% in males and 0.7% in females. It was proposed that the lower incidence rates of multiple myeloma reported in Saudi Arabia compared with the global rates can be partly attributed to, number one, the lack of some investigations like immunoglobulin quantitation, but in particular, actually, serum free light chain testing in many hospitals. Second, the high incidence of multiple myeloma among elderly individuals who tend to receive palliative care, sometimes with traditional medicine, rather than a referral to specialized hospital. Third, underreporting of known cases as a result of low multiple myeloma awareness among health care professionals and patients, leading to symptomatic treatment till death. Number four, high rates of misdiagnosis and misclassification and under-resourcing of the National Cancer Registry. In fact, the Saudi Lymphoma Myeloma Group held the Scientific Gap Analysis Advisory Board meeting in Riyadh on January 26, 2018, which represented 6 Saudi specialized institutions, including in Riyadh, Jeddah, and Dammam, in order to discuss different aspects of multiple myeloma management in Saudi Arabia and to reach a consensus statement in each aspect of the disease. That meeting brought together a panel of Saudi experts from King Faisal Specialist Hospital in Riyadh and in Jeddah, from National Guard Hospital in Riyadh and Jeddah, from King Fahd Medical City, as well as King Fahd Specialist Hospital in Dammam, to share their views on current trends and practice in Saudi Arabia and how these compare with the global picture. The panel agreed that 135 new multiple myeloma cases would be expected every year to be referred to the big centers. It was also noted that a considerable proportion of multiple myeloma patients in Saudi Arabia are diagnosed before the age of 50 years, in contrast to the global picture. The panel members agreed that the clinical characteristics of multiple myeloma patients in Saudi Arabia are similar to the characteristics described globally. However, they highlighted the need for a central, unified, and updated national registry to monitor the current trends in myeloma. On the other hand, a retrospective study observed that Saudi patients with multiple myeloma are relatively younger and present with poor performance status and higher international staging system stage disease than Western patients with multiple myeloma. And probably that is due to late diagnosis and late referral to the big centers. There are many reasons for the underreporting of multiple myeloma cases, which may lead to the false notion of lower incidence of multiple myeloma in the kingdom than other parts of the world. Therefore, there is a need for a central, unified, and updated national registry in order to reflect the current trends of multiple myeloma in the kingdom, using outreach campaigns, primary care hospital support groups, and controlled social media support as well. Saudi Arabia is the largest country in the Arabian Peninsula with a population of more than 28 million. And despite healthcare being free to all Saudi citizens, a number of potential barriers to healthcare access and individual healthcare seeking have been reported. While multiple myeloma is a relatively uncommon cancer in Saudi Arabia, it has been reported that the characteristics of Saudi patients with multiple myeloma differ from those Western multiple myeloma patients, highlighting the need for a national study of the trends and outcomes of the disease in Saudi Arabia. However, published literature on multiple myeloma patient characteristics, treatment patterns, as well as outcomes in Saudi Arabia is scant, unfortunately. The average time for the disease to be diagnosed and for the patient to be referred from the first presentation may be as long as 1 year. And I can remember 2 years ago, there was a patient referred to our center here, and he was really suffering from severe pain. When I took the history from him, he told me this pain started 1 year ago, and I was shopping everywhere and visiting every hospital, and they did not diagnose me until recently. And he has a frank multiple myeloma. It is recommended that the development of education, fully awareness of multiple myeloma, early presentation, and quality improvement programs to improve early diagnosis, patient adherence, and compliance rates. Issues around the availability of drugs have led to the development of local management guidelines in some Saudi institutions. I can admit here, really, in Saudi Arabia, we do have a good number of anti-myeloma medication. IMiDs, for example, we do have thalidomide. Nowadays, we have Regimen, lenalidomide, proteasome inhibitor. We do have Velcade available, as well as carfilzomib. Still, we don't have the oral proteasome inhibitor. And monoclonal antibodies, we do have actually Daratumumab, and next year, inshallah, we are going to have more monoclonal antibodies. Other improvement needed in the management of multiple myeloma in Saudi Arabia, complete FISH analysis, and also CD138 enrichment. You can see from this slide, this is what is available in big centers in the hospital as a FISH panel for patients with multiple myeloma. But comparing this to MSmart from Mayo Clinic, showing that we are not doing everything. We are lacking gain 1Q, we are lacking trisomies, and this is not good actually, especially when we are labeling our patient high risk or low risk or standard risk disease. And I think cytogenetic analysis should be available all of the abnormalities. This is one of the challenges we have to work on it actually. The second thing really, other improvement needed in minimal residual disease testing, because it's not yet available. In one big center here in Saudi Arabia, they are still starting validating the test. In the other center, we are actually waiting, and hopefully in 3 months' time going to be available. We know that undetectable minimal residual disease can be associated with longer progression-free survival as well as overall survival. That is not only in newly diagnosed multiple myeloma patient, but also in the relapse setting. As you can see here, really, those patients who have undetectable minimal residual disease, we can say that probably they do have operational cure because the relapse will take a long time. While those patients actually, by our criteria nowadays, stringent complete remission or complete remission, still they will have a relapse within shorter time comparing to the undetectable minimal residual disease patients. The value of minimal residual disease negative status confirmed by pooled analysis of 3 GEM clinical trials And you can see here progression-free survival as much better in those patients with minimal residual negative comparing to complete remission, near complete remission, and not only in progression-free survival, but also in the overall survival. You see the curve here for those patients with minimal residual disease negative comparing to complete remission or near complete remission, i.e., we can say that the true value of CR relies in the minimal residual disease status, and CR without minimal residual disease is no better than PR, partial remission. The new response criteria, according to International Multiple Myeloma Working Group in 2016, recommending that we have to move away from stringent complete remission and complete remission to the new response criteria, where we have to use minimal residual disease status for the patient, either sustained, using flow, or using sequencing. But more important, actually, using minimal residual disease testing with imaging studies. And that is really to tell that patient is get rid of his myeloma. Minimal residual disease negative status should be diagnostic for treatment and the stage of the disease. And minimal residual disease negative status is the new CR. Either next generation flow or next generation sequencing are feasible because both of them sometimes difficult to be available in one center. Improving treatment paradigm in multiple myeloma using updated evidence-based medicine treatment is very important and very challenging here in Saudi Arabia, including induction for those patients with newly diagnosed multiple myeloma patients, whether eligible or ineligible for transplantation, consolidation, or autologous stem cell transplantation, in tandem transplantation, as well as relapses. For example, ISMO EHA guidelines in 2021, they put for the newly diagnosed multiple myeloma patient, first option induction is VRD. And in Saudi Arabia, we are using VRD, at least for the last few years. But Dara VTD, in fact, I can say here, VTD, our history with it is not good. Because when we tried it a number of years ago, actually, many of our patients developing peripheral neuropathy, and probably that can be explained by that diabetes mellitus is high, with high incidence in Saudi Arabia. So we were avoiding VTD, and now European people, they are using Dara VTD. And I think, and I hope that within a short time, we are going to use monoclonal antibodies in combination with VRD, and we are fully aware of the Driven study and its result. If induction first option is not available, VCD also. VCD we used it actually from 2008 until recently for the last 2 years ago. And it was working very well with our patient, and I will show our experience later. Melfluffin as conditioning regimen, we are using it. Lenalidomide in the last few years, the majority of the hospital here in Saudi Arabia, they are using lenalidomide maintenance for a number of years so far. When it comes to first relapse option after VRD, whether lenalidomide proteasome sensitive or lenalidomide refractory or lenbot refractory, there are a combination of drugs for treatment. And we do have a good combination, some of these combinations available in Saudi Arabia. However, we don't have everything, in fact. For example, pomalidomide, still it is not formulary in number of hospitals here in Saudi Arabia. However, we do have monoclonal antibody, Daratumumab, Carfilzomib, and Dixa, and we can use it in some difficult situation. However, pomalidomide, if we shall ask for it, it will take might be up to 4 weeks to be available if you would like to use it for some of our patients. For second or subsequent relapses, we do have the ability and we do have good drugs with combinations to treat our patients. But what we are lacking really in the management of multiple myeloma in Saudi Arabia, clinical trials. We don't have clinical trials. And I think this is a big challenge for us to start doing trials for our patients and to find out how is our patient behaving comparing to the Western. Study showing us that still there are poor outcomes in heavily pre-treated patients, and we have to look for some solution for this problem. Unmet needs in the treatment of multiple myeloma, as mentioned before, extramedullary disease, patients with early relapses, patients with high-risk cytogenetic, patients with central nervous system involvement. Fortunately, it is not common. It is rare, actually, but it is really very bad disease. Heavily pretreated patients. That means we are looking for some new treatment or paradigm of multiple myeloma treatment for these patients. If we shall look at the potential outline of a future landscape after the treatment of patients with induction and transplantation, and then they will relapse, we can put them into 3 groups with the intermediate groups, and this is the most big number of patients here, or late or early. In late relapses, in fact, we can use the previous combination of treatment, and that will be no problem. But if it is not, if we would like to use more or for a second line, we have to go for CAR T-cell or C-limit agent in which it is not yet available in Saudi Arabia. The biggest group here, intermediate, we can use pomalidomide, dexamethasone, carfilzomib-based combination. Again here, CAR T-cell is coming, as well as bispecific conjugate, and so far are not available in Saudi Arabia. The last group, which is a small group of patients, actually, usually they will relapse within a short time after the transplantation. And the first option here is CAR T-cell. As I mentioned, not available yet in Saudi Arabia, and hopefully within a short time going to be available. And this is the CAR T-cell therapy, and you know the mechanism of action. As you mentioned before, United States Food and Drug Administration approves Bristol Myers Squibb and Bluebird Bio's Abicma, which is the first anti-BCMA CAR cell therapy for relapsed or refractory multiple myeloma. I have mentioned that, I would like just to touch on the milestones of our section, which is hematology, stem cell transplantation, and cellular therapy at King Faisal Specialist Hospital. In 1980, actually, bone marrow transplant unit was established, and the first allogenic transplantation was performed in 1984. When it comes to a multiple myeloma program and multiple myeloma autologous stem cell transplantation program, we started in 1997. And I'm looking forward in 2020 to start the first myeloma CAR T-cell infusion. You know that in King Faisal Specialist Hospital, the first CAR T-cell infusion was started in December 2020, because now we are accepting patients referred for CAR T-cell therapy in lymphoma and in ALL. I'm going to talk with you about the experience treating multiple myeloma at King Faisal Specialist Hospital. This is a single institution experience. Our protocol started in 1997 and so far going on. Our protocol was a high-dose therapy and peripheral progenitor cell rescue for patients with previously untreated stage 2 and 3 multiple myeloma. And this is our therapeutic schema at the start. Newly diagnosed multiple myeloma stage 2 and 3, 65 or younger, they will go for VAD chemotherapy, induction treatment 3 to 5. And once they achieve complete remission or very good partial remission, they will move to the transplant arm. We did not do many allogeneic transplantation because at that time, updating literature discouraging the use of allogeneic stem cell transplantation in multiple myeloma, except for trials, clinical trials. But we continued with autologous stem cell transplantation. The protocol description that, and we used that chemotherapy as outpatient and IV infusion. And the cycle will be repeated every 28 days until 2004, when the novel agent became available and thalidomide dexamethasone becomes the induction treatment for multiple myeloma, we used it. Then when a proteasome inhibitor became available, we used thalidomide, Velcade, dexamethasone. And finally, we found that our patient responding and really doing well with CVD without much peripheral neuropathy. And that we started actually in 2009. And we continued that until 2017, in which we moved to VRD, induction treatment for our patient. Mobilization. We use cyclophosphamide 1.5 gram per meter square and the growth factor. And the successful rate, more than 95%. And the conditioning regimen, we used, and still we are using Melfluffin 200 milligram. It is the standard conditioning regimen all over. But the maintenance story is really somewhat different, because in 1997, we used alpha interferon, but then we changed it into bisphosphonate when they became available. Then we changed our maintenance into thalidomide plus or minus steroid. But since 2017, after the approval of FDA for the lenalidomide maintenance, we are using lenalidomide maintenance for the majority of our patients, but not for all of them, because some of them, once you are mentioning the side effects of lenalidomide, they will say, please, doctor, we don't want to use it. And it is a good number of patients, actually, they are declining lenalidomide use. So the result from that experience, 267 patients, 156 males, and 111 females with male to female ratio 1.4, diagnosed with multiple myeloma, underwent autologous stem cell transplantation from 1997 to 2020. The median age at presentation was 51. Most common subtype is IgG-Kappa in 43%. Most patients presented with advanced stage disease up to 47%. And this is probably delay of the diagnosis as well as delay of the referral. 100 days mortality is 0%. However, one patient died at day plus 88, but he relapsed at day plus 59. We used, and we are still using, high dose Melfluffin as a standard. This is the cumulative incidence of relapse, 68.35%. What about the overall survival? The 5-year overall survival, 65.8%. But the 5 years disease-free survival, 27%. In fact, the conclusion from my talk, as we don't know exactly the incidence and the prevalence of multiple myeloma in Saudi Arabia, there is a need for a central, unified, and updated national registry to chart the current trends in multiple myeloma patients in Saudi Arabia. Outreach campaigns, primary care hospital support groups, and controlled social media support groups should be used to ensure a high level of awareness of physicians about the common presentation of multiple myeloma. Prompt access to tertiary healthcare is needed for multiple myeloma patients to overcome current delays in diagnosis and treatment. And in fact, during the meetings and during talking to our colleagues in the other hospital, we are encouraging them to refer the patient as early as possible, even though there is no confirmation of the disease. And in the last 2 years, actually, I had 2 patients referred to me as a multiple myeloma, and finally, they were diagnosed with breast cancer. One patient recently referred to me as a multiple myeloma, and finally, the final diagnosis becomes Hodgkin's lymphoma. But we are welcoming this actually referral, just not to miss a real multiple myeloma diagnosis. The healthcare authority needs to address the high cost of medication and availability of drugs to improve treatment outcomes. Well-designed studies are needed to address the optimal assessment of minimal residual disease and to unify the management of multiple myeloma through study protocols and local guidelines. Patient-centered treatment is needed to improve patient adherence and minimize the risk of severe adverse events. Improve the cooperation between treating centers in the kingdom, and to have Saudi guidelines for multiple myeloma management is really very important. Need for new treatment strategies involving CAR T-cell therapy to bridge the gap towards unmet medical need in multiple myeloma is very important, and other new medications also. This is the King Abdullah Center for Oncology and Liver Disease, where we are located. And thank you very much for your attention.
Thank you so much, Dr. Fahad, for highlighting big challenges we are facing overall in Saudi Arabia. I think for the sake of the time, we will just leave the questions to the end, and we'll move on with the last presentation for tonight. We'll go back to you, Professor Orlesky, for the next presentation about the overcoming challenges and optimizing care in multiple myeloma patients.
Well, thank you again, and thank you for the excellent presentation just now. I think that there are wonderful opportunities for you to work together within Saudi Arabia and with the international myeloma community to help patients everywhere have improved outcomes. For my second presentation, what I wanted to do is focus on relapsed and refractory disease, but this time look at the late relapsed or refractory patients. In general, these are folks that have had 4 or more prior lines of therapy. And unfortunately, some of the therapies that I'm going to briefly present to you have not yet been approved even in the US, but nonetheless, hopefully will be available soon and maybe eventually be given earlier in the disease process. These are kind of my principles for late relapsed refractory disease, where unfortunately, most of the novel agents have already been used. Also, the combination of a higher disease burden, side effects from many previous therapies, and medical complications often limit the ability to give triplets, and therefore sometimes there is a greater need or tendency to give single agents or doublets, as well as offer clinical trials. And of course, in this population, as in earlier patients, there is an important role for supportive or palliative care to maintain the quality of the patient's life. We talked earlier about selinexor with bortezomib and dexamethasone in a triplet for earlier lines of patients. You can also give selinexor with dexamethasone as an oral doublet. And you can see here that that is effective even in patients with so-called penta-refractory myeloma, which means that their disease has progressed on 2 proteasome inhibitors, 2 IMiDs, and an anti-CD38 antibody. And the progression-free survival and overall survival are shown here. They probably would be better if you could give them in a triplet, and you can really give this combination with a variety of drugs, including antibodies. One of the newest drugs that has been approved here in the US, which hopefully you will have soon, is a drug called melfluffin, or melphalanflufenamide, which is a peptide drug conjugate. The reason this is interesting is that it tends to get more concentrated in myeloma cells and is converted inside those cells into melphalan. But because less of it gets into normal cells, there is a greater therapeutic index. So in the table below the text, what you can see is that for very advanced patients, there was a response rate of 30%, which was as high as almost 50% in earlier patients. And here are some of the treatment emergent adverse events, because again, this is a drug that's related to melphalan. As you can imagine, there is some neutropenia as well as thrombocytopenia, but this can be an interesting drug to give. And here you can see the progression-free survival data, which show about a 4-month time in remission. And this is the overall survival data, which is a little bit under 1 year, which is still quite good for the number of prior therapies that these patients have gotten. And this shows you the response duration, where many patients can have a year or more in remission, or at least in their response. And that hopefully gives them also a good quality of life during that time. I'm also very excited about the concept of using antibody drug conjugates. And right now we have one of these approved in the US. It's called Belamaf, or belantamab mafodotin. This is a BCMA antibody with a drug attached to it called monomethyl auristatin F, and it attaches to the myeloma cell. It's taken up inside, and then the MMAF is a microtubule inhibitor, so it stops cells from dividing and ultimately kills them. You can see the response rate here as a single agent is also in the 30% range. That's similar across many of the important subgroups in advanced patients. And the durability at the higher dose of 3.4 milligram per kilogram, as you can see, is quite good. Here is the overall survival and progression-free survival at the 2 different doses. And the toxicities, the main 2 that you would need to know about if you're going to be using this, number 1 is thrombocytopenia. You can see here at the top. And the other one is ocular toxicity. You can get corneal changes, which can result in dryness or blurry vision or double vision. And these patients do need to be monitored by an optometrist or an ophthalmologist at baseline, and also before subsequent doses of therapy. We also, at this past year's ASH, just a few months ago, saw combination data where belamaf was added to pomalidomide and dexamethasone, and you can see 80 to 100% response rates, although the number of patients is still small, but it does show you that, as with other drugs, this agent will probably work even better in combination. And here you can see progression-free survival, which is now approaching or maybe even exceeding 1 year. So it'll be exciting to see where the data ultimately fall. You heard earlier about CAR T cells and the fact that the first of these is now FDA approved. And that's, of course, the BB2121 agent, which also targets BCMA. Nupur Raj published the first data about this agent. And you can see this study was done in patients with a median of 7 prior regimens, and one poor patient had 23 prior regimens, although you could also say that must mean that their myeloma was responding well, or they wouldn't have been able to get that many therapies. You can see that the response rates with this therapy, especially in patients that get some of the higher dose levels, are in the 80 to 90 or even 100% rate, with a large proportion of patients achieving MRD negativity. And the progression-free survival is also about 1 year if you give a good dose of these T cells. And I think that at higher doses, as the data evolve, what we'll see is an even longer progression-free survival. And you can see many patients, as of that report, were in complete remission, and the arrows pointing to the right show that they were continuing in that level of response. You probably know that this is a therapy that you have to give after first lymphodepletion with cyclophosphamide and fludarabine, so that there are some hematologic toxicities, and then also cytokine release syndrome can be a challenge as well. In these categories, there are also other drugs that I think are interesting that are not yet FDA approved, but I thought I would just briefly call some of these out. And these are the so-called bispecific antibodies, which essentially is a molecule where one end comes from an antibody that binds CD3 on the T cell, and the other end of the molecule here in red comes from an antibody that binds to a protein on the surface of the cancer cell. A lot of these have targeted BCMA. There are many of these, and I didn't have enough time to review all of them. So I did just pull out one abstract of a drug called teclistamab. And you can see here that this was a patient population that was fairly heavily pretreated, with an average of 5 to 6 median prior lines of therapy. And almost all of them had triple class exposed, and many of them had pentadrug exposed and refractory disease. You can see the overall response rates of testing are about 73%. One of the advantages of these bispecifics is that it's an off-the-shelf therapy and does not require collection of the patient's T cells and then modification and engineering for several weeks. And again, there are multiple BCMA targeted bispecifics, and we're not yet sure which one will work the best. Because there is concern that BCMA targeting may result in relapse of patients whose myeloma is BCA negative, there also are other bispecifics that are targeting different cell surface proteins. One of the more interesting ones is this G-coupled protein receptor family member 5D called talquetamab, and this is available both intravenously and also has been tried subcutaneously in trials. Once again, you can see median prior lines of therapy of up to 6. High proportion of patients refractory to most of the drugs that we can currently give. And here are some of the response durations. This study is still relatively early, but again, you can see many patients responding for a year or more, and that's, I think, really encouraging. And then finally, another bispecific is targeting a different cell surface protein called FcRH5. And this also is showing some good activity in heavily pretreated patients with 6 or more prior lines and response rates of about 60%. And I would expect that this will be higher with, again, good durability and some patients able to stay on treatment for a year or more. Once again, in the more advanced setting, you have the same 3 monoclonal antibodies. I mentioned in my earlier talk that there is some data about reusing monoclonals, and we have amassed some data that we're hoping soon to be able to submit in a publication. We have now actually 25 patients, but as of ASH, we had only 15 patients. These were folks that had progressed on prior Daratumumab-based therapies, on whom we gave isatuximab with pomalidomide and dexamethasone. And you can see that if you had Dara at any time previously, the response rate was quite good. It was a little bit lower if you had the Daratumumab as the just prior line of therapy, but still a 53% response rate, which is not bad. And you can see that many patients were able to achieve a partial remission. And so I do think there is some rationale to be able to use one anti-CD38 antibody after the other, especially if the previous use of the CD38 antibody was in a prior line and not in the most recent line of therapy. And as always, this was a relatively well-tolerated combination, with most of the discontinuations due to disease progression. So the conclusions that I would leave you with are that in later line relapsed refractory myeloma, because these patients are a little bit more beaten up, sometimes single agents or doublets with new mechanisms of action are the way to go. And that can include small molecules like selinexor or melfluffin, CAR T cells with ide-cel now approved, and maybe cilta-cel will be approved later this year. We have antibody drug conjugates, so the first one already approved, and bispecifics that I think are looking encouraging and probably will be approved, although there is still a persistent unmet medical need here. As I mentioned earlier, we did publish a couple of years ago algorithms that are still, I think, active and helpful for refractory disease, and we're going to be updating these soon. And please feel free to reach out to me directly if I can be of help to you with any of your myeloma patients. So thank you very much, and I'll turn it back over to the moderator so that you can have time for questions.
Thank you so much, Prof. Again, it was a very elegant presentation discussing a very difficult to treat group of patients with several relapses. So just for the sake of time, we will just take a couple questions because we are running out of time. So there's a question about, this is to all panelists, like both speakers, the experience in treating young patients in third or fourth decade with multiple myeloma. I guess talking about the treatment mainly.
Well, unfortunately, there are some younger patients that we're seeing now with myeloma, including, as you mentioned, in the third and fourth decades. I still manage them in the same way as an older patient, and I do it based on what their molecular risk is by cytogenetics and FISH and potentially sequencing, as we talked about earlier. And I do utilize high dose therapy, especially for patients with high risk disease, and also for patients with standard risk disease if they cannot achieve a complete remission or MRD negativity. And then we do have some clinical trials now that are looking at incorporating CAR T cells earlier in the treatment algorithm algorithm for myeloma, which I think is one reason that I strongly support Dr. Al-Sharif's thought to try to get the Saudi Society more involved in clinical trials for myeloma, because it's a great way to get some of the most exciting new agents available to the patients in your country as well as in ours.
Perfect. Thank you. Any experience from your side, Dr. Fahad? Patients in their third or fourth decade? Do you treat them differently?
In fact, we are using the usual combination of treatment as available. We don't have the new medications to start with. Here, Dr. Orlesky, please, I would like to ask you, are you using minimal residual disease testing now in your center, and are you following your patient accordingly with this test?
Yeah, great question. And the answer is that I do use MRD testing. What I try to do in particular is use it in the newly diagnosed setting as people are going through induction. And if patients can achieve a complete remission and MRD negativity, I offer them the option to collect stem cells and store them away and just remain on maintenance. Because if you look at the IFM 2009 study, the patients who achieved CR and MRD negativity did just as well, whether that was with VRD only or whether it was with VRD and transplant. And if they are not MRD negative, then I go ahead and do the transplant. And of course, all groups get maintenance, either lenalidomide if they're standard risk, or we do lenalidomide usually with bortezomib or with ixazomib if they are high risk.
Are those patients under clinical trials, or just on routine basis you are doing it?
We do that routinely, although we also have clinical trials, and one of the national studies that we have currently is a trial that's comparing lenalidomide to lenalidomide and daratumumab as a maintenance, which we designed through SWOG, and we're about 400 patients in out of a total of 1,100 patients. So it'll still be probably 3 more years before it's fully enrolled. But we hope to be able to show that adding daratumumab in maintenance is also a very helpful intervention for patients.
The other question, please, if you allow me, regarding monoclonal antibodies, are you including them with induction treatment? Because I'm believing really, for example, in lymphoma, CHOP chemotherapy was for a long time until the monoclonal became available. So our CHOP now is more superior to CHOP. I think in myeloma, probably this is going to happen, really. Monoclonal with a triplet induction treatment going to be superior to what we are doing now. What do you think?
I agree with you. What I try to do, because we don't yet have VRD with daratumumab FDA approved here, and some insurance companies will not cover it, what I do try is to be a little bit selective still. And the groups that I use it for, number one, are high-risk molecular patients, because I do believe that daratumumab, and I think isatuximab will do this also, will add to the MRD negativity. So I do it in high-risk patients, and I also do it in patients with high disease burden. And just to give you an example, if somebody comes in with 90% involvement of the bone marrow with plasma cells, it's more difficult to get that patient into a complete remission with a triplet. And so I try to use a quadruplet in those patients, especially whether they have high risk or standard risk disease. So those are the two settings in which I try to do the quadruplet right now.
Thank you very much.
Thank you.
Perfect. Thank you so much. I think we ran out of time. I would like to thank our speakers for excellent and elegant talk. Thank you, Professor Orlesky and Dr. Fahad Sharif. Good to see you all. Just a quick announcement before we close. This is the first official announcement of launching the website Salamat Dimmak, which aim and target patient with hematological diseases, both benign and malignant. So this is the barcode, and this is the website. It will target patient and help patient from different aspects and provide education and help. Thank you so much, everybody. It was nice to meet all of you. Thank you, all the attendees, and good night.
Thank
Night,
you,
everyone. Thank you.
and have a nice evening or a nice day.
Thank you so much.
Thank you.
Thank you, Dr. Fahad. Thank you, Dr. Yunus.
Thank you very much. Thank you.
Thank you.
Assalamu alaikum. Ma sha Allah.